welcome, Mary Claire, honey. We met about a month ago, and it was so much fun. And that pink dress you were wearing was fire. You just looked so good in that color. And I'm just so glad. I've been prepping for this interview for a couple days now. And the first question out the gate that I have for you, because what I love so much is not only your authenticity, but your ownership in your journey. And I think that's why so many women relate and connect to you at a very deep level, at a very visceral level, because they're like, yeah, that's me. With maybe not as much information, but that's what I'm going through too. And so the first question I want to just ask you was in the journey of perimenopause and menopause for you, what were some of the most profound changes that may have taken you off guard, or that may have said to you, my goodness, like, no one told me?
So I was traditionally trained OB-GYN, like med school, residency, and 4 years of residency. And I get out and I'm practicing, and I am like a badass obstetrician. I'm a decent gynecologist. I'm doing all the things. And I had a few menopausal patients, and I was doing my best with what I was taught. But most of my practice was on younger patients like me. So we're all aging together. They have babies, I have babies, and then we're moving, through the practice pattern. And so when I was in perimenopause, or the perimenopause years, I was actually treated because I had polycystic ovarian syndrome. So I was on hormones to suppress that condition. So I really kind of skirted through most of my perimenopause without many obvious symptoms. Now that I look back, I was starting to have joint pain and a few things, but I didn't recognize it. So then I was about 48, 49. And my practitioner and I decide, okay, let's stop the medication and see where you're at if you're fully menopausal, because then I could change the dose, right? And go on the menopausal doses. If I was even going to do that, like maybe I could tough it out and be strong and not need hormones. So I get off. Immediately, my brother has end-stage liver failure. I rush home to do his end-of-life care, and he dies, long story short. And I was devastated. I mean, we were very close, and I, took a few days off to, take care of him, and then the funeral and everything. By the time my days were up, so when I got back, I had to go right back to work. And I would just I had about a 20, 30-minute drive to the office, and I would to save my cry for the drive home. And I would get home and I would just go into the pantry and stuff my face, and I wasn't sleeping, and I was just horribly depressed, and I couldn't think. I mean, I couldn't even function around my kids. And I was like, I'm grieving, never got counseling, never did the things I should have done. And then finally, after a few months, I can feel the grief starting to lift, but I'm still not sleeping. I'm waking up at night, rolling over in bed from pain. I'm so brain fogged. I'm like getting in the car, and I can't, I remember all the memes and the jokes about, you can't remember where your keys are, or where was I going in the car, and losing my train of thought when I was discussing complicated things with patients. And I'm like, when was my last period? Oh my God, I think I'm in menopause. I could not even recognize my own menopause. And immediately when it hit me, I was struck with this sense of, I'm less of a person. I don't know if you ever saw the Sex and the City episode where Samantha thought she was in menopause and it was this horrible thing. I felt like her, this was the end of my life. I was never going to be the same. I was somehow broken, but I was going to muscle through it. My sleep was so poor. I was losing my mind. Plus I was gaining weight. And I thought I'd gain weight, and I had, because my nutrition and exercise had fallen off through my grieving. And I was like, okay, time to get back to your healthy habits, and which at the time were work out more, eat less, and eat an occasional apple.
What we've been prescribed by everybody out there.
I've told my patients for years to do, and it stopped working. I'd have some powder too, and it would just slap right back on. All the tricks and things that I'd done for years to maintain homeostasis with my weight were not working. I was calorically restricting down to 900 calories some days, doubling down at the gym, and nothing would stick. What I didn't realize was all those years of calories in, calories out had chipped away at my bone and muscle strength. I was down to no muscle. I had stopped going to the gym during my grieving process. I had just wasted away. And that's when I was like, I've got to try hormones. I have to, I have to sleep. I'm snapping at the kids. My relationship with my husband's starting to deteriorate. I can't go on like this. So I started hormone therapy, and it was like a miracle as far as my sleep, and like feeling like, okay, I can do this again. Like I can manage what's on my plate. The weight was still an issue. Like HRT is not a magical weight loss program. So then I got,
It's great for that.
so, metabolically, all of a sudden, I go in for my annual, my cholesterol shot up, my A1C shot up, hemoglobin A1C, which is a measure of, for your listeners, a measure of insulin resistance, was in the pre-diabetic range. And I was like, whoa, I weigh, like I'm still heavy for me, but I'm not morbidly obese, like what on earth is going on? And I started reading and started researching and getting into nutrition and more about menopause. And all of a sudden I'm like, whoa, all these things are being associated together. And then no one taught me this in school. Like no one talked about cholesterol and menopause other than like you get older and your cholesterol goes up, but that there was a definite correlation to loss of hormones and that this happens to women in premature menopause, surgical menopause at any age. And I'm like, so I start digging into the premature menopause data and the premature ovarian failure and the surgical menopause. And I'm like, all this stuff is happening to these young women. This is happening to us too. So I just rabbit hole after rabbit hole of every organ system in the body is affected by our loss of estrogen, progesterone, and testosterone. And it's not positive. So I start talking about it on social media. And then people are asking me, all of a sudden, it's like I'm in all these exam rooms. I'm getting all this feedback by the thousands instead of my little one-on-ones where maybe I saw 1 or 2 menopausal patients a day. I'm getting 10,000 comments on frozen shoulder, 10,000 comments on tinnitus, 10,000 comments on, knee pain, 10,000 comments on genital urinary syndrome and menopause. And I'm like, we are doing something really wrong here. And so I would start digging in the data and be like, this data's here and no one's talking about it. And then I read Estrogen Matters and got to see Avram Blooming and Carol Tarbus give the discussion, and it just rocked my world forever. Because up until then, I was still under the assumption that HRT was dangerous and I was risking my life and my patients' lives by giving them hormone therapy with the risk of breast cancer.
I want to pivot there too. One, I just want to honor you in that experience and honor women in how many of us have other things going on, a family member who dies, children that we're caring for, maybe low thyroid function well before we get into perimenopause and menopause. I spent all of last year chasing down the dragon. And it was perimenopause. Like I was like, it's got to be this, but it's got to be this. Like, and I was like, oh no. On the other side, once I kind of dialed a lot of things in, I was like, oh no, some of this is still very much here, and it's 100% perimenopause. And I thought to myself, like, gosh, I've got to be one of millions of women who are trying to find the answer, and just can't seem to to shoot the arrow in that.
The moving donkey, pinning the tail on a moving donkey, just like chasing this horse that's donkey around. It's crazy.
And I just so appreciate that story of just like, okay, a lot of this heavy grief is coming, it's subsiding, yet symptoms that I thought would subside with that aren't subsiding at all. And so I'm curious about the reframe. I just want to honor your experience because I know so many women are thinking, oh my gosh, like I had that kind of experience and I didn't know. Like I came off of, I don't know if it was an IUD that you were on or it was birth control or whatever, came off, and all of a sudden you just got just shoved, like someone just shoved you into the menopause, hole, into off the cliff.
And get a vasectomy, whatever. Yeah. And suddenly contraception is not your responsibility anymore. You're like, woohoo. All of a sudden you're hit by a truck.
Yeah. So I'm so, and just sending so much love to you, because like having to navigate that. And then the eyes open of like, oh my gosh, so many women are being gaslit, are trying to navigate this, don't even have answers. And so, you get on hormones, you're wondering if you should have your patients on hormones. Obviously, the World Health Organization was still kind of standing tall-ish. I know it's been, we've kind of
20-year-old retracted data. Yeah.
And then the consensus of research is pivoting, and you realize, oh my gosh, whether women have symptoms or not, because some women do skate through perimenopause, and goodness bless them, but either way, systemically, we know whether you have symptoms or not, your body changes. your body changes, especially on the big ones, metabolically, cardiovascularly, brain, a muscle, bone. So, looking for an option in terms of an optimizer like hormone replacement, where is your position now? And how have you seen that turn the tide for your patient and community?
So now in my clinic, I only do menopause care.
Yes.
Perimenopause, menopause, postmenopause, wherever she is in her menopause journey, I'm a menopause practitioner. And, gave up the babies and the pap smears and all the routine screening. We've got tons of gynecologists who can do all that, because this was such an underserved population, and that's where I wanted to be. So looking at my patients, about 85% have elevated cholesterol new to menopause. They're bringing me in their labs from prior visits in their 30s and 40s, and their cholesterol was fine. They had no familial cholesterolemia or any of that stuff. And then all of a sudden it goes up 20, 30, 40, 50 points with no real changes in diet and exercise. The weight gain, mostly visceral fat gain. I can measure that in my office. Tremendous gain, or women who, look, I've done nothing. I was a triathlete. I was, going to the gym 6 times a week. I was, eating healthy. I eat clean, doing all the things that maintained homeostasis and health before suddenly aren't working. And it's the most frustrating thing, because you go to your doctor or your trainer and they're just like I said to my patients for years, work out more, eat less. And they're looking at me saying, I did. And, old Mary Claire would pat them on the knee and say, well, I just have to work harder at this age, or welcome to your new normal. I mean, I was the problem. I didn't know I was the problem because we weren't trained, but I will never be the problem again. And I'm trying to teach everyone who will listen to me.
Absolutely. So yes, being a part of that solution. So I know part of that journey for many women, especially when we're looking at lipid profiles and insulin resistance and, other, kind of other inflammatory markers, hormone replacement very much is a part of that solution.
Right.
And I was curious. So yeah, I'm just going to be, I'm on Prometrium. For me, the major shift and swing was the perimenopausal rage. And let me tell you, that does not go well with potty training.
A toddler in perimenopause, so many women are going through that. It's just,
And I'm really curious on the data regarding that. How women have babies at perimenopause, declining hormone levels, increased prolactin, and depending on how long you breastfeed, do you just default over?
So kind of a mini menopause, MINI, is postpartum, especially with nursing, because your estrogen levels are suppressed so low because of the elevated oxytocin and prolactin levels. I mean, this is a physiologic thing because it's a way to keep us from evolutionarily, if you're nursing a toddler, a baby, you don't want to get pregnant again because it behooves you to raise one kid at a time. And so it's nature's way of spacing out your pregnancies about 2 years apart. But the side, and there's some evolution, or we've had anthropologists look at it. If you wake up a lot at night, that's better for the baby. If you're sweating a lot, it's better for the baby because you're warm and you put the baby on your chest. So there are some advantages to that to help with the health of the baby. We kind of go through it all again in menopause, with that dropping estrogen level.
Well, I even wonder, so where, I was kind of looking at the time continuum last year of 23. I stopped breastfeeding my son in July. So it's not even been a year since I stopped doing that. And obviously estradiol levels had been down, and I started seeing glimpses. I think I was curious because it felt like, from an N01 experience, my body was like, you're still in postpartum. We're kind of going to leave you alone you have your own perimenopause situation you got going on, but it feels different. And then as my body kind of knew I was creeping out of that, I just felt like I just got sucker punched so hard. And so it was the rage and the migraines came back and just I was just like, what is this? And it was the extreme fatigue that just brought me to my knees. And hence why I was going down all these rabbit holes. I'm like,
it's got to be my thyroid. It's got to be. And sometimes it is that. But
I have Hashis. Oh, I was like, did I increase my thyroid antibodies? Like, what have I done here? And it was very much perimenopause.
It's hormonal zone of chaos is the best way I can explain it. It's a downward trend, but it is literally a roller coaster going down because as the egg quality declines, the FSH and LH pulsatile things get so much higher because the way I can best explain it, your brain, the hypothalamus, and it's just constantly checking for estrogen in the blood. And it's like, are you good? Are you good? Are you good? Oh, it's getting low. Okay, pituitary, start pumping out LH and FSH to start stimulating those eggs, get one of those eggs to ovulate, and we're creating estrogen by doing that. But then the eggs can't respond as well. So the pituitary is like, more, and then it just shoves this load of LH and FSH. And then you have this massive ovulation. That's why we see more twins when people get older. And then boom, your estrogen levels can sky high. It's temporary. And then they plummet again. And you're just on this roller coaster. And then the next month, everything's kind of back to normal for a little bit. It's crazy how it goes.
It's crazy. It feels crazy. I will say that the Prometrium, the micronized progesterone has been super helpful. But one of the I was sharing with you kind of my mammogram experience, and one of the reasons why I was obviously doing that because this is the age to do it. But also I my estradiol peak hasn't been. It's starting to let me know. She's like, I'm not showing up the way I used to. And so the thought, based on some of the symptoms that have been so glaring for me, was a very low level estradiol patch to kind of even out the symptoms. Hence why I've been going down this beautiful journey. And actually the patch is it's at CVS right now. But I'm holding off given the information I had shared with you earlier. But I was curious how, I know you take care of so many women in perimenopause, but I think that's for so many, that's kind of like, what is happening to me?
We do. Well, unfortunately, that is the least studied phase of the menopause journey is peri. It's barely recognized amongst healthcare professionals as a thing. I mean, I get back all the time. That's not a thing. It's made up. That's not made up. It's actual thing. So we don't have a lot of data to say, clearly you should do X, Y, Z. We don't have a lot of algorithms, but I can kind of walk you through what I do. Early perimenopause, there's things that are definitely due to low progesterone and irregular ovulation. So we can give progesterone, or usually early, we can do a progesterone supplementation only. We can do it continuous or cyclical, and low enough doses to where it won't inhibit the ovaries' production of estradiol. Now, once the estrogen deprivation starts happening with the hot flashes, night sweats, there's a few things that are really, really like, you can't blame it on anything else. That's definitely menopause, low estrogen. And so then we can to supplement her through those low bits, give a really low dose patch, not enough to suppress ovulation. You still need contraception just in case, but enough to kind of shore you up through the transition. Now, a few patients, I'll decide to suppress ovulation, especially if they're having really heavy periods or really bad PMS and I just want to suppress. So occasionally I will use a higher dose and maybe a birth control pill. There are some birth control pills with estradiol. So with just plain estradiol, not ethanol estradiol. So, it just depends on. So when we look at birth control pill versus menopause hormone therapy, the biggest difference really is dose. And then we look at formulation. And so I try to stick to what the ovaries made because I'm giving you back the water you were drinking, which is estradiol and progesterone, which is Prometrium, the brand name. Oral micronized progesterone. So it's really individualized. It's some trial and error. I ask my patients to bear with me. I wish I had a cookie cutter, like, oh, you get this and you get this. But I tell her, and you know what, this might work for a year or two, but you're still changing in the background. Your ovaries are still, going through that process of ovarian failure, or ovarian retirement, as my followers like to call it. Failure sounds negative.
She's been working so long.
So yeah, they need a break. So as you're getting closer, we may need to do dose adjustments. So just bear with us.
Yeah, I know in the perimenopause, kind of transition, there are so many different situations. Obviously, women can be dealing with other things as well, like maybe they have low thyroid function. And so I did that. It is very unique and in a way very complex. And I was curious around, and I know just in your personal experience working with women, topping them up, whether it's just the micronized progesterone or a little bit of estradiol, have you seen, as you watch them through the continuum of menopause, and I know you've been seeing patients in this type of practice for a couple of years now, but I'm curious to know, this is what I'm interested in, is am I setting myself up for success systemically, metabolically, muscle-wise, brain health? If I'm managing symptoms and also knowing that I'm systemically.
So we have pretty good data on mental health that's been looked at. So women who started hormone therapy in perimenopause have less exacerbation of pre-existing mental health disorders and less new onset. So we know that you start early, you're going to do better. Looking at the data from the WHI, I mean, we did get good data out of the WHI, all the cardiovascular data. So the earlier someone started in proximity to their menopause, so maybe she was peri, the lower her incidence of heart disease. So it's really more about when we look at risk, metabolic risk, it's the gap away from estrogen, the time away, the more increased risk. So there's nothing magic about 60 or 10 years. It's just if, a lot of people are like, well, my doctor said I can only have my hormones for X amount of time. It's not going to be worth it. I'm like, no. The further you get away from your starting hormone therapy in your menopause, the less likely you are to have benefit of protection from cardiovascular disease and stroke and dementia. So as early as possible. Not a lot of data yet because not a lot of women are being treated in peri. They're being told, come back when you're a year without your period. We can't treat you yet, but we're getting there.
Yeah, we're getting there. And that's where, I've just been really, that's kind of the data I'm looking for, the information I'm looking for. Cause my thought and based on the data is that so many massive changes happen in this transition that once we get to a place where levels are they're menopausal low is what I like to call them. They're gone practically, they're so low that, how well are we going to bind back to those receptors when we've been in this declining chaos for a decade?
So the estrogen receptors, we know they can be back upregulated in the skin. In the intima, it's a little tricky. In the intima is the lining of our blood vessels, right? That's where the plaques form for atherosclerosis. So for like heart disease and what's going on in the brain and the brain plaques and dementia, estrogen's more better at prevention than cure. Mm-hmm. So once these processes have started, estrogen's probably not going to be helpful, or reverse those changes. And so I'm just encouraging patients as young as possible, if you want the maximum cardiovascular benefits, the maximum brain benefits, the maximum bone and genital urinary benefits, we need to start this as soon as possible.
Okay, thank you. And I was curious, I'm gonna have you share how to know you're in perimenopause and menopause in just a second, but also when you recommend a baseline of labs for women. So let's say lipids, hemoglobin A1C, fasting insulin, ApoB, triglycerides, HDL, we can get baseline early. Let's say at 45, even though you still probably look good, maybe you're doing okay, but you've got this timeline of labs, and at 45 you see an uptick in these labs, even though maybe symptom wise you don't necessarily notice anything yet, right?
Well, yeah, perimenopause begins well before your periods. Oh, yeah. Well before you have a hot flash. So the minute they get to my office, no matter, and most of my patients are coming in for menopause or to get ahead of it or in perimenopause, I'm getting the whole set. I want to know their baselines. I'm asking them to bring in their labs so I can look and have a baseline to compare. But remember, average age of menopause is 51. Normal is 45 to 55. Peri starts 7 to 10 years before that. So some women at 35 will start having changes that we can associate with menopause. Some women it won't be till 45. So I'm checking everybody.
Awesome. And let's say we do see all of a sudden a major shift in labs, even though they're like, I feel fine. Would that still, obviously nutrition and a lot of those other lifestyle recommendations are a major player here, but would that even warrant potential hormone replacement support without symptoms?
I am having these conversations with the patients who are asymptomatic, but having lab abnormalities, and we've ruled out, obvious causes. We've looked at their diet. I do a full nutrition profile on my patients. And, I'm like, it could be protected. Let's do an experiment. Start you on a low-dose patch. You're not super symptomatic, and recheck these labs in 6 months and see where we're at. And we've seen improvement.
I love that. I was just curious because I know that especially for us as women, though I think women do feel that disruptive belly fat and all of a sudden fat redistribution, and then we see the labs and the labs kind of correlate that as well. But I know that's not the case for everyone.
But for most, and they come in so demoralized because they can't figure out what they did wrong. And I'm so sick of society blaming a woman for these body changes because she's fat or lazy or didn't take care of herself. And it's ridiculous.
I agree. I agree. Yeah, I get that there's so much nuance. I'm asking because I have, just again, I've been looking at labs for so long and I've seen so many changes happen in the 40s and, and adopting nutritional changes and lifestyle changes, but maybe not seeing the needle move the way that I would love,
Yeah.
for years. And I was like, okay, what else is there? And now the shift around it's hormones. This is what's driving this, or at least some of it. I mean, not to say that lifestyle isn't a part of that for sure, with the amount of ultra processed foods and how busy women are. I mean, there's a lot of things that are playing in. And so I want every tool in the toolbox.
Right.
I'd love to talk about some of your other favorite tools that you find really help to move the needle on top of hormone, what I like to call optimizers.
So, outside of hormone therapy, which is a big part of the discussion, I use the word toolkit, toolbox with my patients all the time, and nutrition is really the most important thing. So she comes in with a 24-hour recall. We look at what she's eating, how much, how often. I'm getting some nutritional labs, and we're really looking to see where her deficiencies are. Like, that's an easy thing to fix. I'd say 85-90% of my patients are not just low, I mean, deficient in vitamin D. And multiple reasons for that. Gut microbiome changes, intake is low, not worth protecting our skin from the sun, and for good reason. So, we got to get that shored up. Magnesium, people are not getting enough magnesium in their diets, omega-3 fatty acids, fiber. So when I frame it, a lot of women are coming really motivated about the weight part of it. Really, that's what brought me to the table for my own menopause, was the frustration with weight gain that I couldn't get off. And what was this happening with an inner tube around, where's the belly coming from? And when I frame it in terms of let's get rid of the visceral fat, here's what you need to do, everyone pays attention. So let me give you, so these were actually studies done in menopausal women, and women who got 25 grams or more fiber in their diet per day have less visceral fat. Women who have less than 25 grams of added sugar, not sugar found in fruits and veggies, but sugars added in cooking, processing, and alcohol, have less visceral fat. Women who have diets rich in probiotics, and usually with, yogurt, kimchi, miso, or supplements, do better. Turmeric has been shown to be helpful independently, as well as berberine can be helpful as well. There's a few other supplements, So when I address it, I'm not like, this is going to cure your menopause. No. The only thing that's going to cure your menopause is getting an ovarian transplant or considering hormone therapy. But nutrition can go a long way, because with menopause, we see so many areas that we can work on. And when you're just focusing on calories, we're so often just missing the bigger picture.
I totally get that. And thank you so much for kind of naming off those nutrient deficiencies. I see vitamin D, like not even on, like out of normal range,
Yeah, horrible. Like, wait,
how are they on the radar? It's under 30. It's, it's just like, I've seen them in the 20s. I'm just like, oh, we need to get this up to 60.
Yeah.
At least. And so I really appreciate B vitamins. I see women struggling with as well. And so I really appreciate going through, and you're right. Addressing nutrient deficiencies, that's cellular power. That's making sure that your liver's working properly. Yeah. I mean, like that's foundational is what I consider. And then, like you said, the nutrition piece, which the probiotics, I try to get women up to 30 plus grams of fiber, and that's a lift. But I mean, I just feel like we're better off that way, especially around insulin resistance and a lot of those metabolic issues. And then protein too is a big part of kind of what I'm recommending. And so I love that the nutrition piece is there. And obviously there's a lot of other symptoms that happen, like you had mentioned, tinnitus, frozen shoulder, joint pain, hair loss. I mean, collagen loss. We see wrinkles. All of a sudden our nails are not the way that they used to be.
Tinnitus, vertigo. I mean, those people go crazy when I talk about those. Chronic cough, itchy ears. It goes on and on and on.
I mean, I think it's like close to 50 different types of symptoms that women could register for on Peri. But the one that always, is for my women when we survey, 80+%, it's weight gain, it's belly fat, it's low energy, it's their brain isn't working.
Fatigue, brain fog. 80% of women will have musculoskeletal pain, musculoskeletal syndrome of menopause. And for 20% of them, it is the worst, most debilitating thing. It's just shocking. It's not just hot flashes. I say that all the time on social media. Defining menopause by the lack of a period and hot flashes is doing a disservice to women.
a major disservice to women. And I tie that too, again, against estrogen depletion and metabolic issues, like, that it's all interconnected. Vasomotor symptoms are not something to mess with. They're a nuisance, but like they're so much more than that.
And the new commercials, I mean, if you absolutely have a contraindication to estrogen and you have debilitating hot flashes, it can be a lifesaver. Okay. But giving it in place of hormone therapy, like for saying it's safer, it's not treating your brain or your bones, your general urinary symptom, like you're just treating a hot flash. That's it. Estrogen does that for $2. So,
right? Why isn't that the default? That if it's declining estradiol levels that are putting us in this situation, how isn't that not the standard of care? How is
getting started on SSRIs?
That's what I just said. Actually, let me get you started, because we know that the research, hence why, that's how I knew. I watched my mom go through perimenopause, and she almost ran somebody over, because she was just dealing with so much rage. I remember her going to her OBGYN, 15 years ago, and asking, is it okay for me to want to kill somebody, for a couple days out of the month? And what it's felt like to me is a deep sense of dread, and the rage as well. And so that's probably one of the most defining symptoms for me is the mood changes. And so the fact that the option would be, if I were to go to my GP today, if I were to go see her, let's just say, because I have insurance, I run labs, I can run my own labs, but I might as well get them paid for. And I ask for all the things, and she's like, Mariza, you can't have all the things. And then I go run the other ones. I had a big HOB. She won't give me a fasting insulin. So, but I get it. I get where she's at. And so, but if I were to go to her and say, oh my God, I want to just kill my husband, I just feel so much rage, she's not giving me estradiol. I'm not getting it through her.
So, and that's a lack of training and education, blaming the individual. Certainly some doctors should not be practicing medicine. We all know this, but they don't have the right personality to like listen and understand, and just this constant negating of female experience is got to stop. You're more likely to get, so of 85% of women who go in complaining of menopausal symptoms, 85% of women will complain. Only 15% will be offered any treatment. And the most likely thing, 2 to 1, that she's going to be offered is an SSRI.
Yeah.
The most likely time a woman's going to commit suicide is between the ages of 45 and 55.
It feels so real for me, so real. And I just knew what she had to offer. I mean, it's like trying to get milk. I always say it's trying to get milk at the hardware store. Like I'll get her to do, she'll do the things she can do. But like, it's really interesting. I was telling you, I'm getting my estradiol patch, and I can't run it through insurance because I didn't get it through. I'm not getting it through her, and she's not going to recommend it. And so it is, it is what it is. I'm going to come out of pocket for that, but it's what I'm really excited to be on it. And it's interesting us kind of traversing this landscape of how do we get what we need.
Estrogen as prevention, and the medical society, cardiology is there. They said it clearly that estrogen is the most effective prevention for primary heart attack, better than a statin. Works better than a statin. So cardiology is there. The other societies are coming around, but the Menopause Society or ACOG, American College of OB-GYN, have not said that estrogen should be used for prevention of anything except osteoporosis and genital urinary syndrome of menopause. That is FDA approved for those two, but I think we're going to get there in our lifetime.
Yeah. And so I guess the question I have, and I know that this is in your guide, your Essentials Menopause Guide, and this is the question I get all the time. Women tell me, well, I live in the middle of nowhere, or my doctor just won't do it.
Right.
And how are you getting it? What are you doing? And so I'm curious if a woman comes in to their doctor, major mental health shifts and changes, which we know are playing a big role, crazy, awful brain fog. Like they just cannot remember what they were saying. Their sleep is terrible. They're putting on weight in their belly area. We know that hormone replacement would help, especially let's say they're like in their late 40s, where they're knocking on the door. Where do we go?
Sure. So a couple of options. One, the Menopause Society has a list of certified providers. I'm menopause certified. It's kind of a newer thing, and lots of people are getting certified. They do it every 6 months. So there's a wave of new practitioners being certified that have gone through a training program from the Menopause Society. So that's one place to start. Go to their website, menopause.org, and look for someone near you. Still not a guarantee. but it's a place to start. We have a list on my website of testimonials written by my followers. We have hundreds and hundreds of great menopause docs that they've seen. You can go and see if someone's near you. Also, I'm really excited. There's a few of the telemedicine companies that have started, and they don't pay me to say this, but they were founded by women who were entrepreneurs, savvy business people in tech who could not find a menopause provider. And they're like, I see an opportunity here. So they started telemedicine for menopause. So that's another option as well.
Yeah. And I was going to, and one of my doctors is telemedicine. And so, you know, you got a team, I have a team, you know, someone who manages my thyroid, but it was fascinating. You know, I even debated bringing it up to my GP, like that I was even going to get on any of this, because I didn't think she was going to, she was like, well, none of this, you know, it doesn't, you know, qualify like that, which I could just know the answer. And it's just where she's at. It's just, and I know it, you know? And so I think that there's something to be said about really just owning where your doctor's at, and then finding somebody who can really have that right conversation with you, who is menopause certified.
Unfortunately, it's probably not going to be the wonderful person who delivered your babies and did your contraceptive management and did your pap smears. You cannot reliably think that that's going to happen. 85% of the time, they have no training in menopause, nothing significant.
Yeah. And I got one of your favorite reels recently was, you know, join me while I get my makeup on and I share everything I want to share menopause, and you say nothing. Just that is such a defining moment. And we're in a defining time where more women are going through menopause than we have women having babies. So we really
part of our lives.
Okay, so I want to talk a little bit outside of nutrition and meeting nutrient deficiencies, which is so huge here. I think that even just the shift in hormones is causing some of these deficiencies as well. What are some other things that you have found really moving the needle? So we've got hormone replacement, we've got nutritional recommendations. What else can we offer women during?
Pick up some weights, movement. So I was a cardio queen. I grew up in the 80s, you know, and it was all about aerobics, and we worked out to be thin, and everything was about being thin. And if you were thin, you were healthy. So I hid behind a badge of thin privilege my whole life until I wasn't thin, and thought, well, I'm fine because I'm thin. And I judged patients and I judged people for having a weight issue until I truly understood the biomechanics of obesity. It's a biopsychosocial issue. It's not just being lazy, but what's happening to us is we're losing muscle mass. And we're losing it probably from our 30s on. When we hit menopause, that acceleration goes nuts. Our basal metabolic rate is tied to our muscle mass. And when you're losing muscle mass, you know, if you do nothing different, you're going to lose muscle and gain fat.
Yes.
If you eat the thing. Okay. That is the law of thermodynamics. But what the hormones are doing are making you lose muscle quicker and gain fat in new areas that are inflammatory and making the whole system work less efficiently. So if you don't fight to keep and build muscle, you are doing yourself a disservice. So I'm like, cut back on the cardio, girls. Come on. You know, let's pick up some weights, get it, you know, if you can afford it, hire a trainer, get some videos. There's a bunch of YouTube that's free. Go buy some cheap weights. I wear a weighted vest. I just took it off to do this video. You know, I wear a weighted vest around the house. I'm just constantly trying to cheat the system to hang on to the little bit of muscle God gave me. I wasn't born with much. So, and then 20 years of work out more, eat less so that I could be thin, and I chipped away at my muscle and bone.
And one, such a real story for so many women right now, where they calories, as low calories as possible, work out, run, get on the treadmill, do HIIT training, and not building that muscle. Yet, you know, Mary Claire, you have really, I mean, you have shifted it. You were building that muscle. So I don't want women to think that, oh my gosh, I'm already 52 or 55.
Every age you can build muscle. It's been shown. I mean, there's great studies on women in their 60s and 70s who had never picked up a weight in their life. And they brought them in the gym and trained them. And all of a sudden they're like totally gaining muscle mass and functionality and decreasing their risk of fracture and frailty. So in my clinic, my patients who come in at my age in our 50s, they're like, look, bikini days are gone. I don't care. If I do, great. But if not, I just don't want to fall and break. I don't want to be my mom, because I know if I have a hip fracture, I have a 1/3 chance of death in that first year, even with surgery. If I don't have surgery, that's a 79% chance at the age of 65. So they're like, I want to be able to think and move and take care of myself. Help me figure out what it's going to take to do that. And it's not about calorie restriction for that. It's about good nutrition, moving your body, stress reduction, sleep optimization, and probably hormone therapy to help with that.
Yeah, absolutely. Now, one of the things I saw recently, and there are a lot of women listening to this that are in perimenopause and also in menopause, like that are postmenopause. But one of the things I loved is you sharing what you wish you could have told your 35-year-old self. So just as I would love to hear it, I'd love everyone to hear it as well, because there are women here who are 35, or maybe they're just 41, and they really have that opportunity to make some pivots. Because as you just said, if you do nothing and you just go through perimenopause to menopause, your basal metabolic rate will have changed. Your metabolic system will have changed. Your muscle will have changed. Do anything. That is true. And whether it was symptoms or no symptoms, I don't care what happened. Like, you are going to come out on the other side at, let's say, 51 years old, and your body will have been shifted and changed due to the declining hormones.
So, number one is Mary Claire, 35 years old, nutrition over calories. Stop this obsessive, like thin is healthy, is not helping you, not helping your patients, assuming that someone is struggling with, fat deposition because they're just lazy is absolutely the wrong way to think. And by shifting, my personal focus away from how much protein, be more protein centric. Don't worry so much about fat grams, and, eat good, healthy fats. It's good for you. Get away from the processed stuff. Just because it says diet or low cal or low whatever does not mean that it's healthy. Number two, stop judging other people, based on, understand we all have different genetics. Healthy can look different. Don't use someone's phenotype to determine whether or not they're making good choices. Number three, believe in yourself. Just, you trust in the values that you were brought up with, and the daughters you are raising, because they are watching. So and make yourself a priority. Put your oxygen mask on first. You're not going to be able to take care of anybody else until you take care of yourself first.
Yeah. How often does stress play a role in the women that you're caring for?
God, all of them. I mean, every single one. I have an hour with my first, in my primary patients. I'm blessed to be able to do that. But they have to unpack all of that and talk about the stress in their lives. And I try to come up with systems and things to help them navigate. But what I'm shocked at the end of the day is how much prioritizing other people's needs over your own is chipping away at your own health. And at the end of the day, when you don't have your health, who's going to take care of you?
Yeah, well, and exactly, or even anchoring to, again, if you're not going to be able to continue to prioritize those people.
I look at it this way, and I'm coming from personal experience of, I've lost 3 brothers, my dad, my mom is like going through dementia right now. And it's like, I know I'm not going to live forever. And I know my kids are probably going to bury me. Right. But I don't want that last 10 years. And Peter Attia talks about this, that last 10 years of your life to be this chronic disease driven slog that my kids are constantly having to intervene and come take care of me. And, I want them to live their lives and live their best lives. And our visits together to be fun and filled with joy, and picking up grandbabies, if no pressure on my children, they have no grandbaby, but it's like, I'm really focused on that. If I'm lucky enough to live that long, I really want those last 10 years to be pretty special and filled with health and mobility and the ability to think.
Yeah, well, that's why I love the work that you do. I remember, you read that article where 25% of our lives, we are struggling with chronic health issues, even if we live longer than men.
We live longer than men, but we're in much poorer health. I'm like, what's the point? My grandmother spent 5 years demented in a bed. Oh, that is not my goal. It might happen to me, but I'm doing everything that I can in my power to keep that from happening.
Yeah. And I loved the book Outlive, because it really was, what are the things that we're doing to maintain our strength and resilience, so that that 10 years is great. I have one of my best friends, his mom is the same age as my mom. Understandable. That makes sense. Actually, she's much younger than me, but they're both 62, 63, and grandmas. And her mom, every time she picks up her grandson, who's not even 2, it hurts. Her bones hurt, her joints hurt. And I thought, my gosh, I can't even, I just breaks my heart to know that at such a young age, there's going to be a point really soon that she's not even able to pick him up anymore.
That's 7 years away from me. I'll be That's scary for me. I'll be 62 and stuff.
And my mom, who just ran the Dublin Marathon in October, she can
Killing it.
toss
Yeah.
my son in the air and run with him. She can run longer than I can. I'm always telling her, I need you to lift weights. Like, I love that you run, but I need you to lift weights. But she's got a lot of resilience. And so, I can see these two women, same age, very different levels of resilience. And I just, I want to paint the picture of what's possible there. I want to go over labs really quickly. So I would love for you to share. I know my audience knows what my baselines are. I share them all the time. Like, you got to go get these. But what are your baselines? What are you looking at when you do that first hour review and you finally get labs, and if women don't have them, what are you wanting to see?
So I'm getting pretty much the root. I do the routine labs that you would get at your annual visit. So a complete blood count, a complete metabolic panel. I'm doing a full thyroid panel, not just a TSH. I'm getting a homocysteine. I'm getting a high sensitivity C-reactive protein. I'm getting a vitamin D level. I'm getting B12. I'm getting folate. The electrolytes, MAG can go up and down on a day-to-day basis. I look at their intake, and make some estimations from there. But I'm trying to think what else. A1C. I'm getting a fasting insulin, so we're doing a HOMA-IR score on patients, ApoB and LP(a).
Perfect. Awesome. So that's what we're looking for, ladies. That's what we're looking to demand. So I just wanted to have you share, like, what would be the baseline that you want to look at?
Now, sometimes I'll add stuff to that. If, in their history, I'll be like, this sounds like autoimmune disease. I mean, I'm adding rheumatoid factor or what, if she's coming in with like distinctive symptoms of something, I'm adding in labs to make sure I'm not missing. I'm still a clinician, something that looks a lot like menopause, but maybe something else. I've diagnosed lupus 3 times this year. So.
Yeah. I was curious. And with that thyroid panel, do you run an antibody panel just an antibody?
No, I mean, they're not that. If they come back abnormal, then yeah. So screening for Hashimoto's, I guess that's probably something I should think about.
And well, yeah, I mean, it's so often. I've been screening for thyroid and Haji's forever now, and so often when I see that low thyroid, or even God, sometimes not even low yet, that I'll see elevated TPO antibody. I was just curious because it's an easy tack on. Unfortunately, so many women are dealing with it. I mean, my gosh, more than. At least women are coming to see me hard. Maybe that's why they're coming. Okay, so I just wanted to just share what that baseline should look like as they're starting to look at these in a more comprehensive way. And in your practice, do you ever show, I mean, obviously you're going over them yourselves, but one of the things I'm recommending, because I know that kind of standard labs, they can kind of fall through the cracks. I'm educating my women a lot on how to look at those a little bit more clearly. Is that something that you go through in the book, or do you kind of just list the labs in the book?
In the book, we list the labs. In clinic, we do we do a lot deeper dive, but the book was already almost 350 pages long.
Did you get to keep your references, or did they go?
A lot. Yes, of course. I mean, they're filed away, hundreds and hundreds. Oh,
I'm sure. Sometimes, it's in the book launching process or the editing process. They're like, if you want to keep this chapter, you're going to have to move your references online. So I was just curious.
So no, we have probably half in the book and about half on. Yeah, we couldn't put them all in. It was too much.
Okay. And the other question I wanted to really ask you is, once, let's say women come to you in a menopause, let's say they're even, definitely postmenopausal, they're closer into their 60s. Where do you land? I know the research isn't super clear around, hormone replacement or menopause.
So great question. It's not an absolute no for sure. Let's discuss your risk factors. Hormone therapy, estrogen, will always make your bones better for the rest of your life. It will always support your genital urinary system, both vaginal and systemic. Where it gets fuzzy is we talk about prevention. We know that it's cardio preventative when given at least within the first 10 years. So say I have someone in their 60s and so I'll get her cholesterol or ApoB, make sure that those are elevated. I will send her for a cardiac scan, a calcium cardiac score, to see if she's got calcification. I'm pointing behind neck, but it's carotids and neck, to see if she's got calcified plaques there, because if her score is high, estrogen is probably not going to be preventative and may be harmful. After 10 years, it appears that she loses that protective benefit because she's gone so long, but it doesn't mean the rest of her body's not going to benefit. Dementia looks like it's most affected within the first 5 years. So certainly if the patient's already showing signs of dementia, there's worry that estrogen can make that worse. So again, it's a very in-depth discussion, looking at individual risk factors, getting more testing before we say yay or nay. I just had a patient, 66, still having hot flashes and symptoms.
Oh,
Coming in, cardiac score was pristine. The cardiologist wrote me the most beautiful letter. He's like, put her on it. I was like, okay. So, yes. So there are some allies out there who are willing to open their minds and do the reading. But it's really hard to teach some of these docs new tricks. So it's not an absolute no. It's let's do some more testing. Let's do a deeper dive. And it's a maybe.
and then my follow-up question to that is, let's say a woman is 100% contraindicated for hormone replacement. What are some of the other solutions you're leaning on, or you're leveraging?
So we have to look at the obvious symptoms. So is she having hot flashes, night sweats, joint pain, whatever. For joint pain, turmeric can actually be really helpful. It's been shown to be helpful in arthritic pain. If she's having hot flashes, we can look at Veoza, clonidine, Neurontin are options. We really have to go joint, organ system by organ system. For anybody with cholesterol, HRT or not, I'm going hard on fiber. We're looking hard at her dietary choices, making sure we're, getting things up there. And then, so it really just kind of depends how she presents, and then we address it individually.
And based on some of those modifications, and even with hormone replacement, how often do you recommend retesting? Is it depend on the, obviously it can be case by case. Maybe you want to look at that in 90 days.
Certainly if, we've got her on something and she was doing great, feeling fabulous, and then she's not doing any well. Now she's more symptomatic. I'll get a level. Maybe she's not absorbing. We need to try a different method of delivery. But if she's symptomatically doing great, labs are looking good, everything's fine, I'm not doing a lot of testing, only because we don't have therapeutic ranges. Meaning if your level's 50 and my level's 50, you could feel on top of the world, everything's fine, labs are great, and I'm still on the struggle bus. I need more. And so where I think the interesting data is coming out is looking at FSH as a marker. Definitely for cholesterol. There's some really cool studies looking at FSH levels and risk of hypercholesterolemia. So I'm starting to send, and Dr. Lyon and I have had conversations around this, like I'm starting to do more FSHs on patients who are responders, but we don't feel that they're white there. Let's get an FSH and see where you're at. There was a new form for the spray, estrogen spray that came out. I was super excited to try it because I use a patch, and the company gave me had a discount or whatever. So did it for 3 or 4 weeks, started having hot flashes. And I was like, at my FSH, it was 97. I was like, I don't absorb the spray. I don't know why. I have very thin skin, whatever. Not to say the spray's bad. Patients do fabulous with it. Wasn't for me. Went back to the patch. I'm more inclined to do an FSH because remember, the brain is constantly sensing for estrogen levels in the blood. And so it's probably more of a better long-term marker to see how you're doing versus just a random estradiol level.
And then the kind of a quick cluster of questions right here, because I know women want to know, can I test for perimenopause? And, it can be, I think there's a lot of tests to be looking at in perimenopause, but in terms of hormones, it can just be so.
I'm not doing a ton of hormone testing. If you look at the straw plus 10 staging, which is like the Menopause Society has gone through, and they basically define perimenopause by cycle irregularity and hot flashes and some of the symptoms, but they look at FSH. And when your FSH consistently gets above 25, they're saying that's late perimenopause. Some of the that urine test that's come out, Menopause Society is not recommending it. There's a lot of stuff wrong with it. But that is one way. It's like a pregnancy test for the FSH level. And if you have several of those, but it's only at 25. So at 50, we know you're menopausal. That's the definition, above 50. And so 25 can be a marker to help you kind of clue in, but the green scale was developed in 2007. No one uses it. It's completely validated, and it is literally a symptom scoring system. That's it.
Yes.
Like, do you have this? Do you have this? Do you rule out the thyroid, rule out everything else? Yep, you're perimenopausal.
Yeah. And the reason why I know so many women are trying to figure it all out and get clarity. There's a lot of conflicting information around, am I testing these hormones? Should I test these hormones? What's on my hormones? Am I testing hormones? And it just, you can, the landscape it is confusing. And so so FSH definitely one to look at as well. Obviously, a lot of doctors go off, well, again, dosage doesn't always, the example for me is thyroid. Like I suppress TSH just a little bit, but that's where I feel better. When we get me down to optimal TSH levels, I don't feel so great. And so do we work off labs or do we work on how I feel? And so I think that's the same with hormones too, is, are we, is it symptom driven that we're looking at this and we're making dosage adjustments based on symptoms, or are we trying to match it up to what we think physiological dosage is generally?
So right now, most people in my world are using symptoms, but I think we have a lot of work to do to say, at what level is your cholesterol optimal? At what level is a woman's, bone density going to be the best? So, but we just don't have that data yet.
And that's the data I'm looking for too. Yeah, because like I said, I'm systemically, if even women skate through and symptoms aren't there, and yet these hidden underlying chronic conditions are coming up, how do we even nail that? And so that's what, that's why I was wondering where you landed on that too, as you're taking care of so many women in just a variety of situations. Okay.
Pretty much using symptoms. And if she's not responding, then I'm checking labs to be, maybe this method is not the best. She's not absorbing. And maybe we need to switch to oral or something.
Okay. Yeah. And I'm obviously transdermal being, I know you're a patch. I'm really excited to get my patch.
I'm a patch girl, but I'm getting a little bit of flack from people like, stop demonizing oral. I'm like, well, it's not my favorite,
Yeah. And I know that, I'm curious, a lot of us are struggling with liver stuff, like our liver's just not working properly. Estradiol, E2, E1, they go down different pathways.
Oral seems to be better for cholesterol, but the patch is not bad, it's just a little bit better, but oral's not as good for triglycerides. So when they looked at the data, so it's like, so I just go with the patch and hope for the best. But, my own sister's on oral. It's a better economic, it's much cheaper than the patch, readily available. There's no shortage. This is the other thing. So as of the time of this taping, there's a national shortage for estrogen and progesterone. And we're having all these workarounds in my clinics. My patients come from all over the US to see me, world actually, and helping them find, reliable sources is a little tough right now.
Yeah. And it really speaks to the supply and demand. What are we, and maybe
driving the demand by all these conversations, and we just need the supply.
The last, I promise, the very last question is testosterone. I know you're on it. When have you found that to be helpful as well?
So we have the data for menopausal women and libido and hypoactive sexual desire, HSDD. It works, for most women. Desire and a female sexual response is complicated. It's about relationship and arousal, and there's 5 stages. But for most menopausal women, we can see resolution or improvement in her desire. Now, there's 2 FDA approved medications for that as well. They're just really expensive and can be a little bit, by Vyleesi, you have to give yourself an injection an hour before. And of course, a lot of women don't want to do that or plan sex. They just want it to be spontaneous. And then Addyi is a medicine you take every day. It works modestly, but it hasn't been tested in postmenopausal women, only premenopausal. And so most of my patients want to try testosterone. The problem is no FDA approved option for us. So you either have to try to get them the T-stem or the gel for the men, kind of hard to do in Texas, or we have it compounded, which is the rate that I go. Now I'm using it off label for sarcopenia and osteoporosis. I am recommending it along with strength training.
Yes, that's what I talked about was more, off label. I know a lot of women are using it for getting their muscle mass back, building lean muscle mass, and, supporting their libido, but then also helping to support, metabolic health too. So I know that there's a lot of different reasons why women are taking it. It's the hot thing. It feels like it's the hot thing on the market. So many women, even younger than I would have imagined, obviously we know we lose testosterone, precipitously as early as
menopause. Yeah, sure, 50% decrease. So like all of our 99% of our estradiol is made in the ovary, all of our progesterone is made in the ovary. And then the adrenal pathway makes about half of our testosterone. So we don't see as much of a decline, but it's enough where, women notice a difference. So And my patients are pretty happy with it. And I just go with how they, they feel better. They're so grateful. These are relationships where they adore their husband. They had a great libido before. They miss it. They want it back. I mean, it's not lack of desire is not a problem unless it's a problem. So I fully support the woman who doesn't want to have sex and doesn't care. That's fine. She's fine. I'm fine. When she's like, I want this back. I miss it. I love my husband. It's hurting our marriage, but vaginal estrogen, we don't want to fix the libido without fixing someone's vaginal atrophy. And so if she's hurting because of GSM, we must fix that first. And then we address the desire issue.
Yeah, I'm glad you mentioned vaginal estrogen as well as such a major player for vaginal atrophy. Yeah, just discomfort. And women should not ever have to have painful sex.
Ever.
Whew, okay. I'm feeling complete. Let's real quick. The book is coming out. The book is out. So we're sending people to the book. Can you show it?
Yes.
Yes, the new Menopause. It's gorgeous. I'm so excited. Thank you so much. Thank you for being here.